stimulant use, misuse, abuse? Where do we draw the lines? In my opinion, the use of the term misuse is used so widely in such a misleading and divergent way that we should probably abolish the term completely. Abuse is a valid concern and issue with stimulants. Use is certainly there. And there are two very different groups of people that are being lumped in the misuse category, two different groups of behaviors. And there can be some overlap between the two. Why are we paying attention to it now? I am not the FDA, so I'm not inside their heads. So this part is conjecture. I would think their thinking is severalfold. One is, and I'll get into a moment how we define different ways we define misuse, but there is an overlap between misuse and substance abuse or addiction. So we know that those people who misuse stimulants are at greater risk for developing a full-blown substance abuse disorder than people who are not misusing. Whether that's risk is equally applied to everyone in the misuse category, I think highly unlikely, but there is some statistical connection. Two, even if the percentage of misuse and abuse within that category of stimulant users is not increasing, the absolute number of stimulant users is increasing. It's not gone up hugely, but it's gone up measurably. So there's been lots of attention, more people being diagnosed with ADHD in the last 2-3 years, and greater number of Adderall and other stimulant prescriptions written. In non-prescription stimulants, particularly meth, that's one of the fastest growing categories. So we've basically in the US stabilized the opioid epidemic. In some measures, use is going down, whereas stimulants are going up. I wrote about this more than 4 or 5 years ago, before or very early age of the trend, before it was apparent as a trend. And that's partly because there's historical pattern of following opioid crises. There tend to be stimulant crises. Some people think it's a cultural phenomenon that different times, different zeitgeists create different likelihood to use different substances. Others say that it's a purely police action, that if you're cracking down hard on one set of drugs and scrutinizing doctors and manufacturers of opioids, then the criminal element or others will gravitate towards other targets. So that's maybe both explanations are part of what's going on. And particularly the highest increase in death rates from drug overdose. So not biggest percentage, many more people are still dying of opioid overdoses, but it's stimulant abuse, stimulant overdoses are the most quickly growing category of major drug overdoses. In the imprint of the opiate epidemic, more than half of those dying from stimulant overdoses are actually dying from fentanyl-laced stimulants. So the death rate is mostly driven by illicit meth use, and again, particularly contaminated by fentanyl. To put some of it in perspective, the CDC, which collects the best data on this, show that people who are abusing stimulants, that's less than 1% of the US population. Other studies, non-CDC statistics suggest misuse of stimulants is about maybe 10% during the lifetime of anyone in the US. And among on college campuses, so young people, the rates of stimulant misuse are closer to 20%. And if you look at among people who are prescribed stimulants for ADHD, about at least 40% of them are misusing stimulants. So there's a much bigger pool of people misusing than abusing. Another reason to be concerned or paying attention is that most of the problems, most of the disasters that are occurring from not just stimulant misuse, but other substances as well, occur in this misuse category, not the abuse category. So pick on alcohol, it might be easier to illustrate the point. So binge drinking, many people do occasionally. That would be a symptom of misuse of alcohol. That doesn't mean you are an alcoholic or addicted to alcohol. Many people, particularly young people, go on a binge occasionally. So again, the pool of bingers, the people misusing the substance, are much bigger than the pool of addicted people. And the majority of drunk driving incidents, the majority of people who simply die of alcohol poisoning, a frat party initiation gone awry, most of those incidents are among people who are misusing, not among those who have developed full-blown addictions. So again, that's part of the reason for paying attention to this category of people misusing any substance. Now, the problem with looking at this category is, one, definitions for misuse vary widely in not very helpful ways. So most of the researchers who do rigorous research on this, looking at on college campuses, usually define misuse of stimulants as any deviation from how the prescription is written. So that would include any change in how you're administering it. So, and I would certainly say if you're snorting your pills, if you're injecting them, probably you are somewhere on the spectrum of abuse or substance use disorder, rather than just misusing. But also included in this misuse is any deviation from, if you missed the dose, you didn't follow the rules, you are a misuser. If you're late with the dose, if you ran out before you could remember to go to the pharmacy, you're misusing it. If you borrowed your brother's pill or your mother's pill because you ran out, usually the formal research definition is any deviation from how it's prescribed. But colloquially, in substance treatment programs and other places, anytime you use a drug for other than the intended reason, if you're taking it to treat your ADHD, whether you're late with it, whether you doubled the dose, whether you made a mistake like that, by that definition, it wouldn't be misuse. Many of those drug treatment programs would define abuse as taking it to get high. In a moment, be getting into the official substance use disorder, and taking it to get high is possible part of substance abuse disorder, but not the requirement for it. Another definition of misuse that I've seen is taking your medication at a high dose or in an inappropriate situation. Few things we know. So who winds up misusing stimulants? Much more prevalent among the young. Drops down with each age group as you go up. Much more prevalent among males than among females. Who's the biggest risk factor for misusing stimulants? People who have ADHD. That is the biggest risk factor. And it's particularly inattentive symptoms that are a predictor, although clearly in some situations you could see how impulsive decisions, actions could lead to stimulant misuse or abuse. Interestingly, too, the research, and this is not, mostly it's US research, but some of this has been replicated in other studies in other countries, including Iceland. Most of the time when we ask people, why are they taking these drugs not as prescribed, the answer is to help with academic performance. Using it to self-medicate ADHD symptoms, most often they are not taking it to get high or abuse it. So I'm going to jump into the official definitions. And DSM-5 is, as many people say, the Bible. It's not really a Bible. It's more a atlas or map. So a Bible is an invariant word from a God above, and it will never change. The people who wrote DSM-5 know that things will change over time, and that this is our best understanding in the moment to try to categorize how certain patterns of behavior in certain people work and what we can predict from them. So stimulant is a separate codable diagnosis, stimulant substance use, than alcohol or opioids or others. But they're written very similarly, and there are 11 possible symptoms, and you need to be displaying at least 2 of those within the last year to have a substance use, stimulant use disorder. And the more symptoms you have, the more severe the severity of your substance use disorder falls within a spectrum. So the 11 points that they describe are: 1, taking a substance in larger amounts or longer time than you intended to take it; persistent desire or unsuccessful efforts to cut down or control your use; 3, spending a great deal of time either obtaining, using, or recovering from your stimulant; 4, craving the stimulant; 5 is having recurrent use of the stimulant resulting in failures to fulfill major obligations at work, school, or home. So a dysfunction category. Number 6, continued use despite persistent or recurrent social or interpersonal problems. So seeing that it's interfering with relationships and continuing to use it anyway. 7 is social, occupational, or recreational activities are reduced because of your use. So you're just avoiding engaging in life in other ways. That's a little different than 0.5, which is you're actually failing to fulfill an obligation. Number 8 is that you're using in situations in which it's physically hazardous. So again, that could be you're using amounts of it that are posing a risk to you, or you are doing it in places you might be caught, burglarized, assaulted, or you're not aware of your surroundings or able to protect yourself. Number 9, you're continuing to use despite knowing that it's causing ongoing physical or psychological problems. And then number 10 is tolerance and needing more drug to get the same effect. And number 11 is withdrawal, which is having symptom of withdrawals when you are deprived of the drug. To specify that actually both number 10 and 11, tolerance and withdrawal, are normal physiologic responses, even if you're taking the medication as prescribed and as expected. So if you're taking it as directed, then tolerance in that situation or withdrawal are not criteria for a substance use disorder. But again, 2 of these 11 criteria in the last year, this is supposedly trying to cover both street illegal stimulants and substance abuse disorder of prescription stimulants as well. Tested over time, it seems to have some validity. It seems to represent people who are running into problems in their own life and running into problems for society as well, because again, this is causing job failures, relationship failures. That to me seems a reasonable criteria. And I would say that we should only look at misuse that is actually falling into all of this already substance disuse pattern and categorizing it as a problem of substance use disorder, and all the other instances where people may not be taking their medication specifically as directed, we should be not throwing in a misuse category. If we look at the 9, I do have 9 fingers, 9 criteria in the DSM-5, 9 inattentive ADHD criterias. It's not just a few or 1 or 2 of them. Every single one of those basic inattentive criteria make it substantially more likely that someone with ADHD will not take their medications as directly, exactly, precisely prescribed. So I'm going to go through those. So number 1 is lack of attention to details. If you're not paying attention to details, you might not be aware, I only have 2 pills left. I need to get to the pharmacy to get it. You may not read the label to remind yourself of how you're supposed to be taking. Difficulty staying on task. So if you're getting distracted before you're on your way to the pharmacy, but you don't stay on task and take it, or you even get your pill out in the morning and you put it on the counter and you see your mom bought a new brand of orange juice and you're going to try that or compare it to the old one, and you've left the pills on the counter and forgot to take them. So difficulty staying on task is going to make it more likely you are going to misuse your medication. Number 3, trouble listening. When your doctor said, take 2 of these in the morning and 1 of these at midday, or whatever the instruction was, you didn't process it, you didn't hear it. Again, it may be on the label, you could read it, but if you didn't listen and get it in the first place, you're more likely to not take it as prescribed. Symptom number 4 in the DSM, lack of follow-through. So that's a little different, slightly different than being distracted or difficulty staying on task. The end result may be the same, but if you don't follow through, so you have to go to the pharmacy in this coming week, but you don't make a plan, or you make a plan and you forget the plan, or you make the plan and don't follow through with the plan, then you don't get your medicines on time, you run out. Point number 5, disorganization. You may, again, where you keep your medication, where it may be lost, maybe misplaced, maybe out of sight, out of mind, organizing transportation to get to the pharmacy or order it online or whatever you have to do. If you're disorganized, you're more likely to not get your medications on a daily basis or on a prescription refill basis on time. Avoiding tasks that take sustained effort, and that's also sometimes called the procrastination criteria. So again, if you're delaying, I have to get to the pharmacy this week, it's not till Saturday that you do it because there's too much going on, too much coming up, too many other things. That's, again, one of the criteria, inattentive criteria. Number 7, loses things often. If you misplace your bottle, and in the old days, if you misplaced the hard-written copy of your prescription, now they're all electronically sent in. But someone who loses things often is likely to miss either their whole bottle of medication or, again, may take a certain amount out and misplace that, or just the pill they were going to take today. Easily distracted. Again, if you're easily distracted, you may be about to take care of your medicine, take it on the regular way, in the right way, and goes off track. And number 9 is forgetfulness. So again, you may have good intentions, you may have a plan, you may even feel you are ready to carry out the plan. All of these inattentive issues lead to misuse by one of the official definitions. I think actions that are due to inattention should not be lumped. I don't think we should use the term misuse of stimulants there. I think we should say misuse for some degree of intentionality in terms of any of those 11 criteria for substance use disorder. Angle I'm going to address briefly on this is how doctors play into this. So not just psychiatrists who should be more attuned to what's going on with patients with mental health issues, but even ADHD specialists. I know many who've said, oh, they didn't show up for their appointment, I'm not going to refill their prescription, even though they know that the reason, at least in part, the person didn't show up is the very condition you're treating them for. We should be more aware of when we're doing that and not adding to stigma and working with the person to find systems, reminders. I've had people who have 3 different alarm systems and we're aware at 3 different distinct points in the day. Yes, I have an appointment with you. And yet in the hour that it was supposed to happen, they didn't show up. So one of the other things the FDA said that studies fairly consistently show about 60 to 80% of misuse when people getting extra doses or non-prescribed doses of their stimulants, they're getting it from family and friends. Much lower use of getting it on the internet or buying it from a dealer or someone they don't know. Part of the reason is ADHD has a strong genetic component that runs in families. If you forget to get your concerta refilled, but dad still has some of his, then that's an easy and attractive way to share medication. So I'm not advocating sharing medications, but I would argue from a harm reduction perspective, we should seriously consider that in many cases for someone to borrow, obtain, use a prescription stimulant that is not prescribed to them, but to a family member, so they know it's real, it's legitimate, it's there, that may be causing less harmful to their career, to their relationship, to their sense of self, and for them to forego medicine until they themselves can get to the store on time. Again, I'm not advocating for getting missing or borrowing it, but I'm saying we should be more thoughtful when we are evaluating, again, whether the person's acting in their own best interest. Pharmacists do it as well for somewhat different reasons. Many pharmacists are well aware of what the physical effects of stimulants are, and they misinterpret many of the signs of taking too much of a stimulant. Look like someone with ADHD. You may be distracted. You may be nonlinear in your thinking. You may be impulsive. You may be physically jittery or hyperactive. So I think many pharmacists are not particularly trained in diseases or conditions and mistakenly think that many people with ADHD are actually suffering from stimulant misuse or abuse, and that's why they are often not particularly supportive, friendly, or helpful when they're filling their prescriptions. Few things I would urge the doctors to think of things in terms of a harm reduction approach, whether it makes sense to fill a prescription when the patient missed or was late for an appointment. Looking at patterns of behavior is probably more important than any single incident. Some patterns like whether snorting or injecting drugs, that absolutely warning, warning, danger, danger. That's a problem. How about the patient who said, oh, I went on a trip and I left it in the hotel room? It can happen to anyone, but it's more likely with someone with ADHD. To me, it's reasonable at least once to refill the prescription. If, however, there's a pattern of month after month after month, forgetting it or misplacing it, or I'm going out of town on a trip, I need it filled 3 days early. But then the next month, they're going on another trip out of town, they need it filled. It doesn't make any sense because you should still have, even if you filled the previous month early, then you should still have a buffer of 3 or 4 pills to carry you on to the next time. So looking at patterns of behavior, I think is important. I think we should probably abolish, both in the research sense and the colloquial reporting, the term misuse. And we should be looking at behavior that fits on the substance use disorder category. And see, there's questions, so I'm going to start reading them and trying to answer them. Roger is, I'm either addicted or suffering. I can't take it as prescribed. Problem is I can't sleep. I get depressed, so I take a second one. I cannot manage to avoid the cycle. It's hard to tell if I'm better off on the meds or off. With Roger would be to talk with your doctor about how you're actually using the prescription, because it's in your best interest. It's in the doctor's best interest if both of you know how you're actually using it and discuss when it actually makes sense to take an extra dose, which, if it's sanctioned, would not be an extra dose. It would just be an appropriate additional dose. And I would say the number one behavioral issue for getting help with ADHD is getting your sleep in order. And it's hard. It's challenging. There's genetic, there's behavioral, there's cognitive reasons that make it hard. Some of my videos touch on that. I'm not a big fan of medications for sleep, but particularly for some people with ADHD, if that's enough to help regularize sleep patterns, that may be a net benefit. We know it's not just the duration of sleep. It's not just 7, 8 hours you need. It's the same 7 or 8 hours. If you're used to sleeping from close to midnight to 8 a.m., and you try sleeping from 4 a.m. till noon the next day, it's not going to be restful. It's not going to be restorative. It's not going to be affecting you the same amount, even though it was 8 hours. Physicians are under increasing pressure from the DEA or other to cut back on prescribing these medications. Just today, I was talking to a patient. She's been on the same dose of her ADD medicines for the 7 years I've been working with her. And the pharmacy today told her, and it was a new clerk, "Oh, when did you last see your prescriber? I've been out of state. I'm still licensed in California. There's absolutely no federal, state law or DEA ruling right now that says this is inappropriate." The DEA had proposed some changes in prescribing, which they face so much pushback. They are not instituting them at this time. But the pharmacist was asking, when did you last see your doctor in person? And if it was more than 3 months ago, then I'm not going to fill your medication. Pharmacies do have some discretion about filling medications if they think there's medically contraindicated or other problem. But this is a complete misunderstanding of a proposed law, but even the proposed or rule would have said, if I've seen this patient once in her lifetime, then I can continue prescribing indefinitely controlled substances. So even under the proposal, it would have been fine. So yes, there's pushback on doctors, there's pushback on pharmacies. I think we should try to keep using information to push back on misinformed and unhelpful rules and guidelines. I'm not seeing any new questions. So have a healthy, happy week, and I will be back next week.